Good afternoon and welcome to today's webinar, the HCH model, why homelessness exists and what health centers can do about it. My name is Brandy Johns and I'm the Training and Development Manager for Nevada Primary Care Association. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high quality, community-based, affordable primary health care in Nevada. We provide training and technical assistance to health centers and community partners to improve access to health care for all, especially for underserved and vulnerable populations. For more information, please visit us at mvpca.org. This training is in partnership between Nevada Primary Care Association and the National Healthcare for the Homeless Council. I just wanted to take a moment to thank them for helping us coordinate this session. Before we get started, I'd like to go over a few items so you know how to participate in today's event. During the presentation, please be sure to mute your phone or computer so that we don't have feedback or background noise. Also, please be sure not to put your phone on hold or we will hear your hold music. You will have the opportunity to submit your questions to today's presenter by typing your questions into the question panel. We will address these questions at the end of today's presentation. And if we don't get a chance to get to some of the questions, we will contact you after the session is over. Today's session will be recorded and slides will be available to participants. I would now like to introduce today's speaker, Michael Durham. Originally from Nashville, Michael Durham brings a background in foreign service work in developing countries across East Africa, Southeast Asia, and Latin America. Approaching his 6th anniversary at the National Healthcare for the Homeless Council, Michael oversees the Technical Assistance Program funded by the Health Resources and Services Administration, which provides support to the community, health centers, and other organizations that serve people experiencing homelessness. An aspiring human rights advocate, Michael is passionate about centering racial justice in the work to end homelessness and poverty. He holds degrees in political science from the University of Tennessee and theology from Vanderbilt University and lives in the DC area with his 2 children. Welcome, Michael.
Thank you, Brandy. Can you hear me okay?
I can.
Excellent. So my name is Michael, and I'm really happy to talk with you today. I like to say when I start presenting webinars, just to acknowledge that webinars are weird. I'm talking at a screen, and you can hear me but can't see me, and that's not fair. So I just want to acknowledge that and just ask you to pretend that I'm in the room, that we're all in the room together and we're learning together so that we can learn in a community way. So I'm going to talk a little bit about my presentation today. 7 basic principles I want to go over. I like to start with how our organization was founded and sort of situate the conversation in that context. I've got some data on homelessness across the U.S. and specifically in Nevada that I'm excited to share with you guys. We're going to go over some of the history of homelessness and how we got to this place in the United States. And then specifically, we're going to look at the relationship of homelessness to health and healthcare, and then the challenges in serving this population. And then we're going to end with a little bit of a rapid fire, things that you can do to combat homelessness in your own community. And I hope to save some room at the end for some questions, but I've got a lot of slides to cover, so I'll try to move quickly. But first, Brandy is going to...
We're not seeing your screen yet, Michael. There you go.
What about now? Okay.
Yep. Good.
Excellent. So I was about to cue the poll. Brandy, can we do that first?
First.
It should be on your screen, and we'll close it in just a minute. I want to know what your role is at your health center.
I'll wait one more second here. All right, it looks like about 22% are clinicians and providers, 30% are administrators, 10% are support staff, and 40% are other. So
we did, other means we did not have the right categories for everybody, but that's okay. Well, I appreciate that. We can go ahead and close the poll, Brandy. So I'm going to move into the founding principles of the work, and I'll go ahead and say that I put this picture of Bernie Sanders into my slide without, before he had announced his campaign for presidency. The council does not endorse political candidates. That's a coincidence. But it is to say that our organization is rooted in a progressive history. That's a picture of Bernie Sanders and our founding executive director, John Lozier. So our first founding principle is that homelessness is unacceptable. We're coming at this from a place of not just the healthcare perspective, but really from a human rights perspective. Just the assumption that we shouldn't have to be doing this work at all. So the next principle is that every person has the right to adequate food, housing, clothing, and healthcare. And then that all people have the right to participate in the decisions affecting their lives. And I think that really coincides well with the Health Center program and the Consumer Majority Board. And I think that we should always bear that in mind as we do this work, that this is about the people, listening to the people we're serving. Contemporary homelessness is the product of conscious social economic policy decisions that have retreated from a commitment to ensuring basic life necessities for all people. So really what this means is that homelessness is a policy failure. And finally, the struggle to end homelessness and alleviate its consequences takes many forms, including efforts to ensure adequate housing, healthcare, and access to meaningful work, which those are three things often referred to as the three legs of the stool of ending homelessness. And so I just put this slide together in the national conversation about homelessness and whether housing is a human right is often depicted as a matter of opinion, and I would argue that it's not. That it at least is specified in the Universal Declaration of Human Rights. Both housing and medical care are specifically ensured in the Universal Declaration, and so this is sort of just the context that I'm coming from, and as we move forward in today's presentation. So what is homelessness? I'm going to ask you all to imagine a homeless person, or if I say picture homelessness, what is the picture that comes into your mind? So hold that in your mind for a minute while we move to the next slide. So if you belong to a health center, and I think most of you do, you may know this population. This comes from the compliance manual that was produced a couple years ago. So the categories are basically those who lack housing, those whose primary residence during the night is a supervised public or private facility that provides temporary living accommodations, or those who live in transitional housing or even permanent supportive housing. Later in the manual I didn't put on the screen is that includes those who are doubled up. I want to compare this to an older document. This is an old PAL that is no longer on HRSA's website, curiously, but it was one of the founding documents in the Healthcare for the Homeless movement back in '99 as we were beginning to put more shape to what we were doing here. And so the important things I want to point out are that the simplest way you can answer this question, what is a homeless person, is somebody who lacks housing. And it's not a trick question. It really is that simple. It puts it adds other examples of what it means to experience homelessness, but in the federal statute, the definition is as simple as somebody who lacks housing. And the other thing I really wanted to draw out of this definition is what I put in big text below, is that a recognition of the instability of an individual's living arrangements is critical to the definition of homelessness. So really what I'm asking you to do here is blur the lines between somebody who has stable housing and those who don't, because it really is just about the stability of their living situation. So return to your picture, your imagination of what it means to be homeless. And then compare that to the definitions we just looked at on the screen. And I want to ask whether mental illness was mentioned, whether addiction was mentioned, or hygiene, or one of the other stereotypes that we typically have about people who are homeless. And then you'll notice that none of these things were mentioned. And this is really just to say that homelessness is not a personal characteristic, and that people without homes are not another genre of person. Homelessness is a housing status. It's an experience. It's not a character flaw. There isn't a kind of person that experiences homelessness. All of us are vulnerable to it. So that's just sort of an introduction of what we mean when we're talking about homelessness. Now I want to turn to some of the data that we have. So there are a couple of places that you can turn to if you're looking for housing data. The official estimate that most federal data sets will use is the point-in-time count, which is, if you're not familiar, literally what it sounds like. A single night in January, typically, communities across the country go out and they count people, those who are living on the streets, those who are living in shelters, And if you're thinking that's not the most efficient system, I agree with you, but this is what we're working with. And then the most recent PIT counts showed that 552,000 folks experienced homelessness in a single night in January 2018. And I just wanted to point out that that represents an increase. And it's the second. Last year it increased for the first time, I think, in 7 years, and it increased again last year. So the problem is worsening, and this is a big deal. You'll see on the screen I put 7,540 folks experienced homelessness in Nevada during that PIT count. Another place to look for resources or data about homelessness is from the Uniform Data System, and those of you who belong to health centers know this quite well. So all health centers have to report to their total number of homeless patients that they served in a given year. And then the healthcare for the homeless health centers, which are 300 of the 1,400 across the country, have to report the specific shelter arrangements. And so the total number was about 1.3 million patients experiencing homelessness in the US from the most recent data set that we have, which again is an increase from the previous few years. And about 70% of those were seen by the Healthcare for the Homeless grantees, which is to say that the 300 HCH grantees are reporting anyway way more of the homeless patients. And then the data shows that 6,504 folks were reported in the health centers in Nevada. So I just wanted to point out something interesting in that data. As I looked this up, it was curious to me. Across the country, it's typical that the UDS is more than PIT count. It's more than double in this case. And we're used to seeing that because health centers, for one thing, are reporting patients throughout the year, whereas the point in time count is just a single day, a single night, in fact, in January. But not every community has a health center, and so even that is probably an undercount. And many resources that we know of estimate that it's probably closer to 3.5 million nationwide. But comparing that to Nevada, it's unusual that the health center count, the UDS count, is lower than the PIT count. There are a number of possible reasons that might be the case, and that could be something we talk about if we have time at the end to kind of get your thoughts about why the disparity is there. So let's look a little bit more at Nevada. I looked some of this up online, and it was interesting. 99% of people experiencing homelessness from the UDS that in Nevada were served by its 4 Healthcare for the Homeless funded health centers. And that's among 7 total health centers that were reporting in Nevada that year. So what that means then is that the other 3 reported 35 total patients who are homeless combined. This is not to call out any specific health centers, but it is to say that that's probably an undercount. So there's some room for inquiry there to see what's going on, whether it's a matter of screening or where you really are located in a place where very few people are experiencing housing instability. But that's an interesting thing to observe. And I also put the shelter arrangements from the UDS, comparing that to the shelter status across the country. You can see that the other category is really high in Nevada. And so that's another thing that we might follow up on later as we move forward in this work. So how did we get here is the question. Homelessness is clearly a tragedy on its face. It's increasing. So we need to do some analysis about how we got to this point. So we're going to start with some history. Don't you love it when a slide starts with slavery and genocide? But the reality is that the United States was founded on the subjugation of Black and brown people, and we would not be the wealthiest country in the world if not for the exploitation of slave labor and the clearing of Native people. So that really is, even though it's the Debbie Downer for a webinar on a Thursday afternoon, where we find ourselves in the context of homelessness. Fast forwarding significantly, we see that homelessness really spiked in the 80s, and that the literature about homelessness before then looked a lot different. The idea of people who were homeless was, it was not perceived to be like a societal norm. It wasn't necessarily normal to see people panhandling on the streets up until that point. In the 80s, homelessness spiked, as I said, and that really corresponded with Reagan-era budget cuts. The budget of HUD today, accounting for inflation, is a fraction of what it was in the 60s and 70s. So we really, as I said in our founding principles, have retreated from the idea that the federal government has any role or the major role in ensuring housing stability for our population. Related to just the history of racism, we see that housing discrimination and segregation continues and is a major contributor to homelessness historically and today. Redlining is the historical practice of real estate developers, or rather the federal government, delineating which neighborhoods were risky or too risky to insure mortgages. And of course, those were neighborhoods with high numbers of people of color. And so that history really produces the housing segregation that we're still experiencing. Deinstitutionalization, many of you remember what I'm talking about, is psychiatric institutions that closed their doors around the same time period in the 80s, which really removed the safety net for a lot of people with severe mental illnesses. And of course, poverty, it can be said that homelessness is the most extreme form of poverty, but in particular, just the widening of the wealth gap over the years. Housing or wealth is most determined by real estate. One's individual wealth is directly tied to whether you own property. And so with the discrimination in housing, we see the widening wealth gap. And of course, the war on drugs around the same time period and mass incarceration. I think I was reading something just today about people who are children who have experienced homelessness, or it is likely that at least one of their parents has been incarcerated. And so really these are all linked. So we kind of fast forward to present day drivers of homelessness, which are not distinct from the historical drivers, but it's a lot of these things that we're still experiencing. And I'll just highlight a couple. Adverse childhood experiences, ACEs. I'm sure as healthcare providers, you guys are aware of what that means. LGBT discrimination. I think it's still the case that 40% of youth who are homeless identify as LGBTQ+. And that is due in large part to discrimination at home and being kicked out of your house because of your sexual orientation or your gender identity. Social isolation is a big one. Network impoverishment is a term coined by our friends at the Center for Social Innovation, which is to say that for folks, particularly in the literature, folks who live in communities of color, they experience this phenomenon of network impoverishment in which they have an adverse event, they lose a job, they have a medical emergency. They have fewer opportunities for folks to take them in and for their communities to support them compared to other communities, middle-income communities. So moving on to a couple of other things we haven't highlighted, of course, the opioid epidemic is a major contributor to homelessness today. And that's definitely on our minds as health centers and really prioritizing opioids in the movement to end homelessness and also just increase access to healthcare. So I've highlighted in purple the two that I really want to dive deeper into in the next few slides, which are structural racism and the housing deficit. So you can't talk about homelessness without talking about racism. And I don't know whether this is news to folks, but this is a pretty striking statistic to learn that 40% of people experiencing homelessness in the United States are Black or African American, and that compares to just 13% of the general US population. That's a pretty significant disparity. And if you think that that would correspond with the general poverty population, you're slightly mistaken, which is to say that those who are living in deep poverty, about 20-something% of those folks are Black or African American. So there really is something specific to homelessness where we're seeing this racial disparity. And I think if we're dealing with people who are experiencing homelessness, it is incumbent upon all of us that we pay attention to this reality. The two most overrepresented populations within the homeless population are Black and Indigenous people. And that's a callback, if you will, to what we were talking about before in the founding of this country, and it's no coincidence. And I think one way to explain this, as I put on the slide, is that every system that leads to homelessness, if you're thinking about the criminal justice system, the education system, certainly the real estate industry, all of these industries are rooted in a racist history and at least implicitly continue to favor white people. And so that's really, I think, the most simple way to explain this racial disparity that we all need to be paying attention to. And I just threw in this and linked to this paper from 2011 that did a deep literature review into the connection of racial justice and homelessness, and found that people of color have a harder time escaping homelessness, which is to say they have longer bouts of homelessness, and people who are white have an easier time getting placements into housing. So we need to talk about that. And as I was talking with some of the PCA staff planning this webinar, we wanted to highlight, just as we were talking about the racism problem in this work, that there is a workforce component to this. Many of you may know as healthcare providers that there is a pretty big disparity among those in the healthcare workforce. Whereas almost 29% of healthcare for the homeless patients and just over 22% of all health center patients are Black or African American. Again, just 13% of the general U.S. population is. Compare that to the total U.S. healthcare workforce, which is almost 12% Black or African American. But if we're talking about just the providers, as we usually refer to them, so the physicians, mid-levels, NPs, RNs, et cetera, just 6.3% of those providers are Black or African American. Again, our friends at the Center for Social Innovation did some analysis of the homeless services field, which is those who report to the Homeless Management Information System. They found that, again, repeating the statistic, that 40% of people who are homeless are Black or African American. In the workforce, 22% of non-senior management positions are Black, and just 12.6% of senior managers are Black. And so if we really believe that the workforce should look like the people we serve, then we have a lot of work to do, both in the healthcare and the homeless services. And for those of us who are healthcare for the homeless, those are the same thing. And I put a couple of links here to demonstrate that you can read more about why this is important, specifically in the healthcare space, where we know that providers' implicit bias creates health disparities, and I should be racially explicit by saying white providers' implicit bias create these disparities. And on the other side of that coin is that the more people of color in the healthcare workforce, the better the healthcare outcomes for people of color. So this is just something that we need to continue to talk about in our movement. So we're going to do a poll. Brandy, can you do the one about the housing wage, please?
All right. You're at 44% are somewhat familiar, 0% are very familiar, and 56% are unfamiliar. Great.
That means that the next slide is going to be educational for everybody. So let's talk about it. This comes from our friends at the National Low Income Housing Coalition. If you don't know their work, please look them up. One of my favorite things that they do is produce the Out of Reach report every year, and which is a calculation of the housing wage. The housing wage is the hourly wage you need to earn to afford a modest rental home at fair market rent. And by afford, we mean without spending more than 30% of your income on rent and without working more than 40 hours a week. So I hope that makes sense, folks. So let's look at what the housing wages we're dealing with. The national housing wage this year for a 2-bedroom is $22.10. which is, needless to say, a lot higher than the minimum wage. The Nevada housing wage is $18.59, and I think your minimum wage was $8.25, which is $1 more than the national minimum wage, or the federal one. I threw in there. I live in Northern Virginia right now, and the housing wage where I live is almost $35 an hour. And no, I am not making the housing wage. I spend 60% of my income on rent. And so another way of saying this figure is that if you're working minimum wage, then you in Nevada, you need to be working 90 hours a week to afford a 2-bedroom fair market rent. So this is all to say that housing is simply unaffordable in this country. We have an affordable housing crisis. This same report says that there is no county in the United States where you can afford a 2-bedroom at fair market rent, making minimum wage. And in just 22 counties across the United States can you afford a 1-bedroom at fair market rent. And I think you've heard before that just a quarter of those who are qualified for Section 8 housing actually receive it. So we have a crisis on our hands. And if you recall that the core characteristic of homelessness is housing, then we're looking at the problem right here. So that's the main thing we want to keep in mind. So we talked about racial justice. We talked about the housing wage. Now, what is the connection to health? I've got a couple of slides here from 2 different resources. But if you're looking at the screen, you can just observe the disparity that we're looking at, the health status of the homeless population compared to the U.S. general population. Diabetes rates, which is a HRSA priority that everybody is aware of, more than double in the homeless population. Hypertension, pretty significant. HIV, drastically different, drastically higher in the homeless population. Substance use disorder, depression. Name almost any health category, and people experiencing homelessness suffer from it worse. So this is another slide, just some more chronic bronchitis, liver conditions, multiple chronic conditions. Tooth loss is a pretty significant one, 72%. Severe mental illness, 25% compared to 12%. So that's a lot of numbers, but just to demonstrate that the population we're dealing with here, those who are living in shelters and on the street and even doubled up, are a lot sicker than the rest of the population, and we need to keep that in mind if we're doing this work. So let's talk a little bit about why this health disparity exists. And I think a lot of this will be easy to understand if you're working with people who are homeless. The inability to follow a treatment plan is pretty significant. How many times when you see the doctor after an injury or some sort of illness, are you directed to put your feet up or to rest? How many times are you prescribed medication that you need to refrigerate? These are all things that are typically unavailable to folks who are experiencing homelessness, even if they have a shelter. Most health shelters don't allow you to stay there during the day. If you're living on the street, then you are constantly being asked to move along because, in fact, this is a separate webinar, but we've criminalized homelessness in this country. Sleeping on a park bench is a crime in many of our communities. So there's just no place to rest. And that relates to sleep deprivation. Of course, there's a lot of literature to suggest the link between health and sleep. Scarcity of food, of course. The food that our patients have access to is often in soup kitchens or in shelters. And you know that most of that comes in cans. It's a lot of starch, a lot of salt, a lot of sugar, not a lot of fresh produce. It's really difficult to get the nutritional diet that you need to stay healthy when you're experiencing homelessness. Exposure to environmental hazards, extreme heat, extreme cold. These severely affect our patients. I think Chicago recently, I was on a conference call with some folks, our members there, the temperature dropped to something like -30, and I'm from Nashville, so that's ridiculous to me. I can't even picture that. I can't even imagine that cold. And I think they experienced many of their clients with severe mental illness were unable to come in from the cold and really suffered some serious health problems from that. And I don't think any deaths have been reported yet, but it's a major concern for our population. Poor sanitation. Many of you, if this was in the news, have heard that the hepatitis A outbreaks in places like San Diego, I think Kentucky, even various communities across the country. Hep A was spreading in the homeless population, and at least in San Diego, I was there during the height of this. It's directly related to the city's removal of public restrooms. And so there is, frankly, a lot of feces in the street. And so if we're unable to provide a sanitary environment, we can't expect our neighbors experiencing homelessness to stay healthy. Just want to highlight a couple more of these on the screen. Violence, I didn't link to it here, but we did a report a number of years ago that showed that about half of people experiencing homelessness have been a victim of violence. And I think that really challenges a lot of our stereotypes. Stereotypically, if folks are walking down the street and they're people who are panhandling or camping on the sidewalk, people feel like they will be victimized. Where in fact, the data suggests that the people who are camping or panhandling are more likely to be victims of attack or sexual assault even. And so that trauma, other forms of trauma, and homelessness itself is a traumatic experience. And we know increasingly in the literature these days know that trauma has serious impacts on one's health. Minority stress is another version of trauma, which is just the inherent traumatization that people of color experience in the United States by virtue of the color of their skin and the way that they are stigmatized and experiencing microaggressions and even worse race-based attacks. And that has serious implications on our health. So compound that minority stress with being outside all the time, and we're dealing with a significant issue. So, and then the last point I wanted to make here is that it's hard to stay healthy on the street, but folks who fall into homelessness may have been sick already, and there's a likelihood that they already were. And then those conditions will be exacerbated through their experience of homelessness. And this is an article that updated our figure about personal bankruptcies, and it's a slight uptick from the last one we were using. 66.5% of personal bankruptcies can be linked to medical bills or illness. So really, illness itself is a major contributor to homelessness in the first place. And so because our folks are sicker, that it can be harder to treat them, and that's related to a lot of reasons. One is that our patients often are dealing with multiple things. So if you can't just treat their chief complaint because they're dealing with a number of things, and so you're trying to treat a lot of things at once, and usually co-occurring with a behavioral health challenge or a substance use problem. Transients, so our population is moving around a lot, not by their own accord. And in fact, some communities are shipping their homeless population out of the city so that they don't have to deal with it anymore. So that's something to be mindful of. I remember being on a conference call with our program in Houston saying that 40% of their patients they see just once. So that really, it presents a challenge for us, especially when we're talking about provider productivity. So how are you supposed to balance that, trying to treat all these different issues that a patient is presenting with, because you may not see them again, but also want to get them linked into care, to engage in other services so that you can continue to see them it's a real challenge that we face. Transportation access, of course, it can be really hard for patients to reach their appointments because most don't have reliable access to transportation. And because of that, I know that a lot of our members don't even take appointments. They're walk-in only, and some of your members may be that way as well. Behavioral health challenges, as we said. And then insurance. I can tell you, I'm sure those of you who are clinicians on the line are familiar with the challenge of not being able to prescribe something because it isn't covered by a patient's insurance, or they're paying out of pocket. And I just looked at our UDS again for last year and saw that 34% of healthcare for the homeless patients, so that's the 300 across the country, 34% of those patients are uninsured. So that's obviously a challenge to providing care. And then the last two that I think we need to talk about is that this is a major challenge that we see. As healthcare providers, as health centers, our primary concern is the health of our patients. We are concerned about their other social determinants, as they're called, but the health of our patients is paramount. That's just not the case of those that we're working with in the community. HUD-funded providers, other religious shelters, or other organizations who serve people experiencing homelessness. And this is not a judgment of them, but their priority is just not healthcare. Their priority is getting folks into housing, and it really is a numbers game for them. I've been to a couple of these meetings with Continuum of Care folks where healthcare is seen as a luxury. That their orientation to this is, let's get them into housing first, and then we'll deal with their healthcare problems. And I'm not saying that that's wrong, but it does present a challenge from the healthcare perspective that the partners in this work, serving the same people, like at shelters, are just not cognizant of the healthcare challenges and the substance use issues that our patients experience. And don't get me started on the shelters who that have really strict policies for substance use, and that kind of conflicts with the model of care that we're talking about in healthcare for the homeless. And then even for the patients, if you're not sure where your next meal is coming from, then you're not really going to pay any attention to the rash on your back. The survival needs have to come first, and that presents a challenge to us as healthcare providers. So Brandy's going to do 3 quick polls in succession. So we're going to start first by asking about if you belong to a health center, your sliding fee scale. What are we looking at, Brandy?
All right, we're at 54% yes and 46% I don't know.
Okay, interesting. So let's go to the next one, if you don't mind. Does your health center screen for homelessness? That's higher than I thought, by the way, 46%.
Right, I have 73% said yes and 27% said yes, but inconsistently.
And then the last one is asking whether your organization is involved with the Continuum of Care.
Like I have 60% yes, 10% no, and 30% I don't know.
Okay. So let's move forward. We've got about 20 minutes left total, and we'll save some time at the end for some questions that you may have. But the remainder of what I'm going to go through is like a BuzzFeed style, since I'm a millennial, 9 things that health centers can do to address the problem of homelessness. So the first one, and I should say that I recognize that with all of these that it's not so straightforward, that it is a challenge to do what I'm suggesting, but at least for each recommendation that I'm making, I'm providing a related resource on our website that can help you in this process. So screen. It seems like most of you are consistently screening. Some of you are screening inconsistently. If you work for a healthcare for the homeless funded health center, then you are more cognizant probably because you have to report of the specific shelter arrangements of your patients. But if you're not a HCH-funded health center, then you're just responsible for reporting the housing status alone, or rather whether somebody is homeless. It's really important that we are consistent and thorough in screening for homelessness. Because when we don't, as we saw in the previous slide, that the 3 health centers together only saw 35 homeless patients, we're missing a lot of folks. It's hard for me to believe that only 35 people were experiencing housing instability in those communities. So we need to make sure that we are treating the people according to their need. So I think this one is pretty straightforward, so we'll keep going. This one's pretty straightforward too, slide to 0. I've been in a lot of rooms where health center staff are resistant to the idea of charging patients nothing because of the skin in the game idea, which is to say that patients have to have some sort of buy-in in their own health in order to really commit to their health care. And that is just contradictory to the healthcare for the homeless model of care, which is meant to be as low barrier as possible. And in fact, the purpose of a health center is to serve patients regardless of their ability to pay, and that's all health centers according to the statute. So it's just really important that we take this seriously. As a clinician, you don't necessarily have the power to change the sliding fee scale. That's something that the board approves, but you can advocate within your own organization to make sure that patients with no income or who are experiencing homelessness are not charged for their services. So check out a paper that I wrote last year, and this will be linked in the slides when you get them. And number 3 is comprehensive, patient-centered, low barrier, integrated addiction treatment. This is, of course, on the minds of most health centers these days, specifically opioids. So a lot of communities, opioids is not the main concern. Sometimes alcohol is, or other substances. This is just the model of care. This is the standard of care that we're working with in 2019. I've been in a couple of rooms where conversations where there's still a lot of cultural resistance to the idea of prescribing medication to treatment for patients with substance or opioid addiction. And I've heard it said that compared to diabetes patients, you would never refuse treatment to a diabetic who was not sticking to the diet that you recommended or not taking their insulin consistently as you recommend, that you would continue to work with the diabetic patient to improve their treatment and to continue to prioritize their health care. You wouldn't refuse them treatment. It shouldn't be any different for somebody with a substance use disorder. Suboxone and other medication-assisted treatment is really just the standard that we should be living up to as health centers these days. So I think we should take that seriously. And the resource here is some adapted clinical guidelines that the council developed, specifically the Healthcare for the Homeless Clinicians Network. And it just kind of acknowledges all of the challenges in treating patients who are homeless who have opioid use disorders. I can never say that word right. My 4th challenge to you is to get involved with HUD and housing. The Continuum of Care, for those of you who wrote, who said I don't know in the poll, Continuum of Care is the way that Housing and Urban Development basically organizes the federal movement to end homelessness or reduce homelessness in the United States. And so in Nevada, or in most communities, the larger cities have their own Continuum of Care, and then they have a balance of state, which is, well, the rest of the state has a Continuum of Care. You need to know who those folks are, and as a health center, you need to be at the table because without you, they're probably not thinking about healthcare. And so this is a real opportunity for health centers, specifically Healthcare for the Homeless health centers, to make a real impact in the movement to end homelessness in their communities. And we have a lot of our work is dedicated to issues related to linking health centers to other homeless services organizations in the Continuum of Care. So follow that resource that I've linked to. So trauma and trauma-informed care is increasingly a buzzword, and that's a good thing. But we should really be thinking about the trauma of homelessness as people who provide the special care to the special population. This is something that the council has really pioneered, I think, over the last 20, 30 years, the notion of trauma-informed care as it relates to homelessness. And so this really is a core competency both for providers and really for anybody working in your organization that you should prioritize. And we produced a few years ago a 4-part webinar series that we compiled as an online course presented by a renowned trauma expert, Matt Bennett, who, if you've attended our conferences, you've probably seen him speak. This is a really great free resource that we provide to the community, and I hope that you recommend it to your staff. And my 6th one is to be welcoming, affirming, and knowledgeable of marginalized groups. That means queer people, people of color, immigrants and refugees, people with disabilities, and other marginalized people. As we saw in some of these slides before, people who are homeless are more than likely, or disproportionately anyway, probably belonging to other marginalized groups, and so their marginalization is really just compounded and really pushed to the edge of our communities, to our society. So it's just imperative that as health centers that we are explicit about our welcome, about our position of being affirming and welcoming to people in these groups. And so we have a number of resources on our website. The council in particular is prioritizing racial justice in the movement and homelessness, and that's a big part of my work these days, is to help encourage healthcare for the homeless health centers to prioritize diversity and inclusion in this work. We have a lot of resources on our website about transgender and gender nonconforming people, and so that is who are significantly disproportionately represented in the homeless population. So that's a resource that I recommend to you as well. So we're doing okay on time. Coming up on the 7th recommendation, outreach. I think even if you are not specifically funded with healthcare for the homeless, outreach should be a part of your services, because there are a lot of reasons that a patient experiencing homelessness will not come to the clinic. If you are staying in an encampment, you've got a tent in the woods or in downtown or some kind of skid row, whatever your community looks like, all of your possessions are at that encampment. And if you leave the camp to go to your appointment, then there's a probability that your stuff will be stolen. And that's just one example among many of why folks wouldn't come to the clinic. So I think it's really important that if we really are going to be reaching the most vulnerable people, that we need to get out of the clinic. We need to go out to encampments and provide at least services to get people linked into care, if not actual street medicine. And I'll plug at our national conference coming up this May, I'm organizing a full-day session on street medicine. And I don't think we mentioned it in a previous slide, but unsheltered homelessness and specifically is increasing across the United States, especially in the 50 largest cities. And so this is increasingly a necessity for health centers to get trained on. And we have an old but a really good still curriculum on our website called Outreach to People Experiencing Homelessness that I've linked to here. My 8th challenge to you is to center the voice of your patients. As community health centers, you are required to have a consumer majority board, which I think is a really, it represents some progressive legislation actually, that this is a requirement for health centers, and I think it's important. It can be really easy though to tokenize people with the experience of homelessness in your governance structure. And so it's important that we don't do that, that we actually meaningfully elevate the people we're serving in the decision-making process. And so even if you don't have a consumer majority waiver, Regardless of your structure, I recommend a consumer advisory board, specifically of patients with the experience of homelessness, to help inform your services and make sure that they are really centered to the needs that your clients experience. And so that's a huge component of our TA work. We've got a staffer dedicated almost exclusively to this work, so we can help you with your consumer advisory board. And my final challenge is to be an advocate. Health centers are nonprofits, and nonprofits can advocate. And it's important that you be a member of your community as a community health center and know your local, state, and federal policies that are affecting homelessness and get involved. I think as people who are serving our most vulnerable folks, we are uniquely positioned to advocate on their behalf. And again, that's a thing that we can help you with. So I'm coming up towards the end of the hour and want to leave room for any questions that you have. I've got a couple slides here with more resources. So some of the data that I went over comparing the health status of homeless folks versus the general population is in that first Homelessness and Health link. We've got an online course, Healthcare for the Homeless 101, that includes a lot of the material, but more in depth than what I presented today. We've got 1 million archived webinars, and in fact, in March, we're doing a webinar series specifically on women experiencing homelessness. So it's an 8-part series on Wednesdays and Thursdays in March. These are all free. All this stuff is free, and so I encourage you to look that up. And then our adapted clinical guidelines for various conditions, and actually the general recommendations is a really great introductory document for folks who are new to this work. And all of this is on our website, of course. So there are a number of ways for you to get involved. Follow us online. Access technical assistance, that's my job. So if you fill out that form, it comes to me, and we can talk about how we can help you improve your services. I do hope that you'll consider coming to our national conference in DC this May. It really is a culmination of the field, and it's my favorite time, professionally speaking, of the year. And so I hope that you'll consider that. And Brandy, that's my last slide. I think we've got a few more minutes for questions.
If you have any questions, you can either put them in the chat box, or if you want to raise your hand in the attendee box, I will unmute you so you can ask a question. Great. Well, if you do come up with something, you can contact Michael or myself, and we can help you with those questions. Thank you, Michael, and thank you to everyone for attending today's webinar. If you have any further questions, please contact me at bjohns@mbpca.org. Once you leave today's webinar, you will receive a survey on the presentation, and we'd appreciate if you complete that and provide your feedback. On behalf of the Nevada Primary Care Association, the National Health Care for the Homeless Council, and our presenter, Michael, thank you for joining us today, and have a great rest of your day.